good afternoon. It is so great to see you here today. My name is Rebecca Andrade, and I'm the Educational Programs Manager here at the Kansas Health Institute, and I would like to welcome you to the third session of the 2025 KHI Policy Learning Series, Exploring Maternal Health and KanCare, the CARE team. This session is a part of a four-part series. We facilitated the first session in March, where we discussed how KanCare addresses health-related social needs, and then again in June, where we explored KanCare and behavioral health. So a little bit about KHI. We are the Kansas Health Institute, a nonprofit, nonpartisan educational organization based in Topeka. We were established in 1995 with a multi-year grant from the Kansas Health Foundation, and we are guided by the vision that Kansas will become the healthiest place to live through evidence-based and innovative strategies, policies, and practices. We work towards this vision by providing nonpartisan information, convening crucial conversations, and facilitating learning that leads to meaningful change. If you visit our website or you stop by our building, you'll see that our work involves research, evaluation, technical assistance, and policy analysis, as well as podcasts, blogs, and gatherings like today's convening. Okay, and now it is my pleasure to introduce Alexa, who is an intern here at KHI and has been a wonderful partner in all of this work. And so I'll turn it over to her to do some opening remarks.
Hi all, my name is Alexa Hesseltine, as Rebecca just said. I'm gonna start with going over our agenda for today. So we'll get that changed. We have a jam-packed day. We're gonna start, obviously, we just did our welcome, but we're going to begin with a maternal care team overview run by Shelby, and then we will transition into a conversation with the Kansas Department of Health and Environment for a state perspective. We'll then transition into a conversation about KanCare with some managed care organizations, and finally hear from some voices from our care team. So there are two source resources that we'll be referencing throughout today's convening, both of which you should be able to find in the chat here momentarily. The resource guide contains links to relevant publications and additional resources that are being shared by today's guests, along with some discussion questions that we'll be using to guide reflection on topics or conversation with our organization. And you can also find a space where you can take notes throughout today's session. In the chat, you will also find our latest brief, KanCare Maternal Health Team Supporting Healthy Pregnancies, Births, and Postpartum Care in Kansas. So we want to hear from you. We want to first thank you. We know you could be anywhere and you've chosen to be with us today. We have folks across many spaces, healthcare, public health, academia, nonprofit foundations, many different organizations. So we'll just take about 30 seconds here. And if you could put in the chat what is bringing you here today, we would love to hear that. Additionally, we would love to hear what topic or question you have that you would love to explore today. So if you could also just put that in chat. Awesome. So I'm seeing some things like learning as much as we can about Medicaid, working with KHA on maternal health care. We've got lots of different ideas, just wanting to get as much information so you can better serve patients. So we've got a lot of different ideas, and I'm really looking forward to today's conversation. So I'm going to go ahead and turn it over to Shelby. Shelby Rouse, an analyst here at KHI, and she's going to be leading the maternal care team overview.
Thank you so much, Alexa. I really appreciate your warm welcome. So to start today's conversation, I'd like to take a brief moment just to acknowledge all of the folks from KHI who have contributed to this work, from folks that have worked on the issue brief, as well as to folks that have been crucial to creating today's conversation and planning our panels. Just so thank you for all of your collaboration. So before we get started today, we want to provide a brief overview looking at who is on the maternal care team within the KanCare system. So as you'll see, there are a variety of folks and roles who are involved on the KanCare maternal care team, ranging from APRNs to social workers. Within this graphic, you'll see a few that have definitions under them. These are the roles that we'll be discussing today in greater detail. These roles have recently been impacted by KanCare policy changes that have either established reimbursement pathways for their services or have expanded that reimbursement rate for those services. So this demonstrates how policy decisions directly influence both the care team as well as access to maternal care services in Kansas. So next, we'll take a look at the key policy changes that have shaped the care team. So since 2018, three major policy changes or buckets of policy changes have emerged for the maternal care team. So starting with April 2022, this is when the coverage for maternal care services or postpartum services was increased from 2 months to 12 months, dramatically increasing that time that recent parents could be on Medicaid or CHIP. Next, the other two buckets really look at reimbursement pathways being established for new care team members, as well as expanded support or expanded reimbursement rates for a few of our providers that we'll be looking at today. So let's look a little bit more closely at how these changes impact specific providers. First, we're going to look at lactation consultants. So in 2018, this is when services provided by those non-physician lactation consultants became reimbursable under KanCare. Next, in October of 2023, there was a rate increase for those lactation counseling services, as well as an expansion of provider settings that can now reimburse for those lactation services. These include settings such as local health departments. And then finally, in 2023 as well, telehealth lactation services provided by those non-physician lactation consultants became reimbursable under KanCare. So next, we'll look at community health workers. So within July of 2023, services provided by certified CHWs became reimbursable under KanCare. These services kind of fall under a variety of different categories, ranging from screening and assessments all the way to care planning and health education. So they really provide a wide variety of those services. Within the following year, in July 2024, KanCare increased CHW service rates for a few different codes focused on education and training for patient self-management. And within this, the supervision requirements did not change. So next, we'll be looking at doulas. In June 2024, this is when KanCare established training and documentation requirements for doulas to enroll as Medicaid providers. So this was a month before reimbursement was put into place, and this allowed doulas to enroll as Medicaid providers prior to that launch date in July 2024. And in July 2024, this is when those reimbursement pathways became live and doulas could start providing or receiving reimbursement for services provided by doulas. So next, we'll go on to certified nurse midwives. So certified nurse midwives have received reimbursement for quite a long time now. However, in October of 2024, this is when they saw that rate increase for 75% of the physician rate up to 100% of the physician rate. So this kind of reduced that 25% gap that previously they received reimbursement for their services for. So next we'll provide a very brief overview of maternal care in KanCare 3.0. So just to provide that base knowledge, KanCare operates under a managed care model with those managed care organizations delivering services to their pregnant beneficiaries. Within this, in KanCare, in addition to the federal requirements for prenatal, perinatal, and postpartum coverage, these new contracts put more emphasis on providing maternal care services, such as care coordination, mental health, and education, with those increased supports for those with high-risk pregnancies. And then finally, looking at what our MCOs are providing, in addition to those required services, they can provide value-added benefits beyond their contractual agreements. So looking at these federal requirements for KanCare, as well as the KanCare 3.0 contract requirements, as stated previously, those federal requirements include prenatal care, perinatal care, as well as postpartum care. And then looking at the KanCare 3.0 contract requirements, while services provided under previous KanCare contracts may have provided that care coordination or education. The new contracts really put in that explicit detail of services that are required, as well as really emphasizing that care coordination, mental health, and education. Um, some of the big differences within this are looking at that added coverage for high risk pregnancies, as well as um, uh, the educational or evidence-based and trimester-specific education for those beneficiaries. So briefly looking at an overview of the MCO value-added benefits, these are additional benefits or extra services that managed care organizations provide beyond what Medicaid is required to cover. These benefits are designed to support members' health and well-being, in addition to the federally mandated maternal care services. So these benefits really vary by MCO, but fall into the categories that you see on your screen today, such as breastfeeding support, infant supplies, and parenting education and support. Just to provide a brief overview of what some of these specific value-added benefits are, at Healthy Blue, members can receive a $75 gift card to purchase items for breastfeeding, such as nursing support pillows or bottles. At Sunflower Health Plan, members engaged in the Start Smart for Your Baby program can obtain a safety certified car seat or booster seat reward for attending key prenatal services. And then at United Healthcare Plan, members who complete a postpartum visit can receive $100 to purchase baby items such as a crib, diapers, or a car seat. So again, these are those additional services that are provided by individual MCOs to their beneficiaries. So this concludes our overview of the policy changes, KanCare 3.0 requirements, and value-added benefits related to maternal care. I'll now turn it over to my colleague, Sheena Schmidt, Senior Analyst and Portfolio Strategist at KHI, who will lead our KanCare conversations with KDHE, Healthy Blue, and United Healthcare Community Plan. Over to you, Sheena.
Hello, everyone, and welcome. Please join me in welcoming Shalay Harris, the Deputy Director of the Medical Bureau for Kansas Medicaid with the Kansas Department of Health and Environment. I will go ahead and turn it over to Shalay. She's going to tell us a little bit more about how KanCare is addressing maternal care for its members. So we'll hear from her, and then we'll open it up for some additional discussion with Shalay. So I'll go ahead and turn it over to you. Thank you so much for joining us today.
Thank you. Thank you, KHI, for allowing the state to share the great things we've been doing around maternal care. And I want to make a shout out to all our partners and advocates and coalitions and associations. We cannot do maternal care and health policy without all of those passionate colleagues in the state who help us write our policy. Again, I'm Shalay Harris, Deputy Director of the Medical Bureau here at Kansas Medicaid. I am a nurse that works with a small but mighty clinical team that helps write policy and does KanCare clinical oversight for our KanCare Medicaid team, and contract. It is an exciting year here at Kansas Medicaid. As they mentioned, we are in the first year of the KanCare 3.0 contract, delivering Medicaid services to around 411,000 Medicaid recipients, and that varies from year to year, quarter to quarter. And we are, again, contracted with 3 managed care organizations, Sunflower Health, United Healthcare, and Healthy Blue is our newest contractor, and you'll hear from some of those today. Next slide. Again, a large part of my team's clinical work has been payment policy work around clinical initiatives. And many times our policies are developed from working with those state advocate groups and providers that inform our policy approaches that can increase access to services for our members and support providers to bring better health outcomes. So today I'm going to talk to you about our efforts here at Kansas Medicaid for maternal health services from the last 5 years. So in 2020, as we all know, the state public health programs have been focusing on the COVID pandemic and looking for new ways to access patients. The DHCF here, Department of Healthcare Finance, was no different. We took that opportunity to recognize and reimburse the midwife for newborn home visits. This would encourage the home newborn assessments in the home environment and give us that opportunity to add reimbursement to the midwife who was doing those. Code there. I want to mention also, I am not a coder and biller, but I can connect you to the bulletins and resources to the policies that can help you understand what to code for reimbursement. In 2021, we also, it was brought to our attention that our OB rates had been not raised for quite a while, and they had been remaining low comparatively around the surrounding states for the vaginal and C-section delivery codes. So we did the research, our clinical team did that research, comparing states, doing fiscal analysis, and we looked at increasing those rates by that activity. So you can see those codes that were raised, and that was something that we were glad to increase for our providers. We also were informed by providers that the removal of limits of maternal depression screenings would also help with postpartum depression treatment earlier. So with their information and with further research, we decided to remove the limits from 3 screens during pregnancy and 5 postpartum to unlimited or per diem or as needed to encourage providers to catch postpartum depression early and often, to diagnose and treat at the right time. As Shelby had mentioned, and I know in 2022, this was an exciting policy that came through, and working, at that time I was in the space with maternal child health advocates, nonprofits that were pounding that marble floor there at the State House, asking for the legislature to expand postpartum coverage. And we were excited to see this finally come through, I know. And that was because of the provision of that American Rescue Plan Act of 2021, which created the allowance of the state plan amendments for Medicaid programs in the states to extend coverage to 12 months. It previously was 60 days, up to, and now it's up to a full year of birth. That change was approved when Kansas wrote that policy, and it became effective, as Shelby had mentioned, in 2022. Those outcomes there that you see, we are hoping to look for those health outcomes in our data, and we'll be data mining that here pretty soon. Okay, slide 6. Slide 6 is the year 2023, and you can see a lot of bullets there. It was a very busy year for our clinical team and DHCF there. It was a very exciting year. We had some turnover of clinical staff, team members, nurses that had come in from the public health space. We had some new leadership that had come in, Director Christine Osterlin, who is currently directing our Medicaid program, and a charge from Secretary Stanek to start looking more at our MCH initiatives around policy. And so we started digging in with some of our advocates and coalitions to look further at what we could do to impact maternal health care. One of those was working with our breastfeeding coalition, Kansas Breastfeeding Coalition, and you'll hear from Brenda Bandy today, looking at opening up places of service for lactation counseling. And that was opening up the place of service for telemedicine to reach more moms for lactation counseling, allowing video and audio transmissions to be covered and in the patient home. This was important to increase that access for this service to be allowed and to be accessed for the member. We also were brought to our attention by the Kansas Perinatal Community Collaborative, had come to us and asked us to cover the automatic blood pressure devices for self-monitoring in the home. They have a lot of great initiatives that they do and that are going on, believe, around AIM bundles. And this was something that they had brought to our attention, and we looked at the research and that they had been providing to us and everything that was informing this policy. And so we decided that this would be very informative and important to do because of obtaining blood pressure measurements to screen for that preeclampsia, which can be a life-threatening situation, could allow for early identification and diagnosis of this condition, resulting in close surveillance and effective treatment to prevent those serious complications. And then in 2023, we also looked at the second reimbursement to increase those OB global codes again for the vaginal and C-section deliveries. We continue to watch the surrounding states when we are watching the rates, and the surrounding states had been increasing those and we wanted to keep up. So we did that second increase for those OB codes. That fourth bullet there is talking about the rate increase for lactation counseling. Kansas Breastfeeding Coalition came to us again and mentioned, and embarrassingly enough, we were one of the lowest rates. We had one of the lowest rates for lactation counseling in the country. I believe it was $9. And so that was pretty embarrassing. We do not want to be the lowest. So we worked with Kansas Breastfeeding Coalition and researched those rates, and we wanted to be competitive in that space and be proud of what we were giving for lactation counseling. So we increased that reimbursement rate to a competitive rate so we could bring more providers to be employed as lactation consultants in offices. So that would increase beneficiaries' access to lactation services, hoping downstream that would increase breastfeeding rates in the state of Kansas. And next, that fifth bullet is the coverage of RSV vaccines for pregnant women. Medicaid is told by CMS to cover and follow all vaccines under the ACIP vaccine schedule. The schedule states that states will cover all of those vaccines, and we have a nurse that is a program SME, or subject matter expert, that watches that vaccine schedule. And this was a vaccine that came out, and we are told to cover that for pregnant members during the 32 and through 36 weeks gestation. So we added that to our vaccine schedule to be covered by Kansas Medicaid. And we also have added it to the Vaccines for Children, or our VFC program, for those pregnant teens under the 19 years of age. And then the last bullet there, and an exciting one that we were really excited to cover, as Shelby had mentioned, was the first coverage of our community health workers and services. And we couldn't have done that, again, without our CHW coalition and advocates, and several of those that were already working with CHWs and knew the value of those in our communities and to help inform this policy. There's a lot around how they can bill and what they can do and what services they can provide in the state of Kansas to be reimbursed for. So I would encourage you to get on KMAP and search that bulletin. That is the public announcement of the policy and how they can get reimbursement. I can get you that resource through KHI if you would like to know more about that, or connect you to our CHW coalition and advocates that can help inform that as well. So just this past year, our third reimbursement happened for our OB global codes. We knew that we needed to add, we had a physician rate increase overall, and we knew with that we needed to add 6 more codes to the 2 codes that we had increased, bringing that increase to help with that reimbursement of other delivery codes and postpartum codes and antepartum codes for reimbursement. And so we increased those. So that was another reimbursement for our OB codes, adding more. As you see on that second bullet, this was an exciting one. Actually, it had a lot of buzz for our clinical team, and it had a lot of work put into this policy. A shout out to Sapphire and her Kansas Birth Justice Society led a lot of this work came together with Kansas Medicaid staff. I think I was just rolling into some of this work in the middle of this, but they had brought together a work group. We do that sometimes to help inform these large new coverage and policies. And we're very thankful that we had those experts there at the table to inform our doula policy and coverage, and really came to a consensus of how we could decrease barriers to get them to be a provider and enrolled in Kansas Medicaid, and how we could bring those access to services to our Medicaid members. More on that through our KMAP bulletins on how to bill, and Sapphire and her organization also can help you know more about how to bill for those services, and also how to access those services for your Medicaid members if you work with them. And then you see there's a certified nurse, sorry, we're still on that slide, the certified nurse midwife reimbursement increase for certain delivery codes. We had been doing some research, actually, the nurse that has this program, on some physician rate increases and mid-level rate increases with our fiscal team, and noticed that the 25% mid-level practitioner reduction had been eliminated. And that is because of a passage of a House Bill 2279 that was effective July 1st in 2022, which in that Kansas legislature language mentioned that based on the authorization for collaborative practice, it had been stricken and eliminated the requirement for certified nurse midwives to have a physician authorized prescribing protocol, meaning no longer did our certified nurse midwives have to have a collaborative practice agreement with a physician to be able to practice. So we believe that they were due the 100% reimbursement for the delivery codes to help impact our maternal health outcomes. So we took those delivery codes that we could get them reimbursed for, and we made a policy around that, and we called it getting rid of the 25% haircut, and we gave them the full reimbursement of 100%. And then with the request of the CHW Advocates and Coalition, we also increased the CHW rates. They were a little bit lower than what we wanted, but we had to get in the door fiscally to get that policy going and to get them reimbursed. And we brought that rate up again for a second increase for our CHWs. So in 2024 as well, we were charged by KDHE leadership, Secretary Stank and Director Osterlin, in the first quarter of 2024 to work with the Division of Public Health and Healthcare Finance, our colleagues, to come together, cross-collaborate efforts to develop recommendations or a roadmap around maternal infant health initiatives that would need Medicaid support and public health infrastructure to implement. We were doing a lot of the same things, but we needed to come together to bring some synergy around that. So the roadmap objectives that we came up with in the first early days of that work group were recommendations that included access to care, increased data transparency that drives initiatives, and then increase our workforce development. Those outcomes in that first year, we have a 3-year roadmap. That first year was, we heard from our public health colleagues, and then looking at increasing that workforce, we found that we could allow more provider types for mental health telehealth services. We had one of our clinical program nurses work on a policy on that, and that has been recently implemented. We're very proud of offering more mental health services and providers for our Medicaid beneficiaries through that. We did straighten out the fact that Medicaid is the primary payer for special formulas. If you've been in touch with Medicaid and what we've been doing, that recent policy has come out. Also internally, we're exploring our data use agreements amongst the public health State Department and our division, seeing how we could get earlier identification between our Medicaid beneficiaries and into our public health colleagues for various services and departments with those identifications, whether it be for lead identification or early identification of pregnancies. They also were identified about the increase of OB global codes, the increase of CNM rates for those home visits I mentioned, and then we also from that work group identified that we needed a cross-collaborative, just general public health work group and Medicaid interagency work group, and they just launched here this past year, and so we have other colleagues that are working in that work group. So I think some of you are very familiar with what we call the TMA grant. That is not something our team is over, but we're really excited that Kansas was selected as one of 15 states to receive this grant. It began January 1st of 2025. The grant award was $17 million over the next 10 years. It addresses 3 key areas: access, infrastructure, and workforce, as you can see there, quality improvement and patient safety, and whole person care delivery. CMS did require applicants to be state Medicaid agencies located only in the United States with MCH collaborative partners, including their state public health department. I believe some of you probably participated in that application. I watched from afar, but know that we have a whole new team coming on board to implement this grant. As you can see there, we have 10 CMS required elements of that grant work. I have those outlined there. We have a project or a grant director for this, so I could read those off to you, but I know you all can read those as well. But we are hoping, and you can see we have done some of this work, but we are hoping the grant can dive into this deeper and bring more of this expand more of this, extend more of this throughout our state with our partners, and as they have outlined in the grant deliverables that they have outlined. As I mentioned, we have a project director for this grant. You can see there, it's Heidi Hartner. She'd be glad to answer any of your questions. She'd be glad to tell you when we have postings for positions. The latest update is we have hired, I believe, 2 project managers for various pieces of that grant. Hire announcements, they just finished interviews, I know, a couple of weeks ago, and hire announcements for those, I believe, are coming. We still have, I believe, some positions that will be posted, more to come on that, but be watching our website for those postings. Again, you can contact Heidi Hartner if you have any questions around the TMA grant. And Sheena, I think that's the end of my presentation.
Thank you so much, Shalay. Lots of great information, and I know there are lots of interest and questions in the chat that hopefully we can address, and we can do so throughout the rest of the convening. I think we do have a couple of minutes just for questions that I can pose to you, and then if others want to share their questions in the chat or use the Q&A feature, you can click on the more with the 3 dots at the bottom of your Zoom screen, and you can find it there if that's a little hard to find, but encourage you to use the chat as well. All right, so I just had one. We don't have a ton of time for questions, but from a policy standpoint, what are the biggest opportunities and challenges in integrating doulas, lactation consultants, certified nurse midwives, and community health workers into maternal care team? And how is KDHE and other agencies working? How are they working together to ensure that Medicaid policy changes are responsive to the needs of all members across diverse communities in Kansas?
That's a big question. And I know our advocates for each of those provider groups could give you a plethora of ideas around that. But in general, from our state office or agency, I could tell you what we see is the traditional provider groups. I know have a really hard time, I think, integrating those into their practice. I know that we traditionally, the traditional CHW providers, the clinics that use CHWs know the value of those that represent the community and work in the community and bring those services. They know the value of that. They do have collaborative agreements and efforts with some of our larger hospitals and clinics, and they know how to integrate that. But I would not say the traditional provider knows how to use a CHW. Doulas is the same thing. Hospitals are leery sometimes of a doula in that delivery room, and I know Sapphire and her group can tell you a lot about that. So traditional providers, I would say, in systems have a really hard time getting those integrated into their usual practices and processes. We hope our MCOs help with that. We encourage them to use those new provider types in their care delivery with our members. So we're hoping that they can help catapult that to a different space.
Thank you so much. A great discussion, and please stay and join us and chime in on our next couple of panels. Thank you so much for providing that information and for sharing all the work that the state is doing in this space. We really appreciate your time today. All right. So now we're going to transition to conversations with a couple of managed care organizations who are charged with providing services to pregnant beneficiaries on KanCare. Um, and so I'm joined today by Thamara Submaranian, the deputy the health equity director with Healthy Blue, who is an MCO, and Stephanie Jurgensen, the Healthy First Steps maternal program coordinator with United Healthcare. Thanks for joining us today.
Thank you. Thank you for having
Yeah,
us.
yes, very much so. All right, well, I can go ahead and get started. And I know if you have information to share, I know Thamara may have a couple of slides she wants to point out in answering our questions. So we will just go ahead and get started. To start, could you tell me a little bit about how your organizations are addressing the needs of pregnant and postpartum postpartum care for members? What are you hearing from KanCare members about how their needs are being addressed?
Stephanie, you want to go first?
You go ahead.
I'll
jump
Okay.
in after.
Well, I can share. I'll just share one slide first to just start off and kind of show an overview of what we share via Healthy Blue as a KanCare MCO provider, some of our internal programs, as well as some of our community partnerships that are really spearheading. Yes, exactly the slide. Thank you, Sheena. So, first of all, as Sheena had said, and Shalay had said, maternal health is such a key pillar to KanCare and what we do at Healthy Blue, and our goal is to provide equitable, affirming, and accessible maternal care from pregnancy through postpartum, which it's wonderful that it's now acknowledged as a year past giving birth. And to do this, we've recognized from just listening to members who are on Medicaid and are pregnant or have given birth through Medicaid, sometimes finding that postpartum care, whether it's having a question being answered, I have a high blood pressure reading, what do I do? These things are really hard to get answered for many of our members on the spot, especially if they're in rural areas. If their provider or care team, isn't available at all hours. And just like with the reality of being pregnant, it's tiring and it's exhausting and also can be really disempowering to reach out for help. So some of the internal resources we have are concierge care. This is basically our Healthy Blue clinical team, care coordination, OB care coordination team provides virtual telehealth OB services for any Healthy Blue member who is pregnant or postpartum. This helps them better connect to their OB providers. We also, to incentivize this, we have an OB quality incentive program. This is a Valley-based program we'll be starting next year to encourage OB providers to do more of those social determinants of health screenings and assessments, quality assessments, behavioral health assessments. Doing this and then also connecting the members to the resource is something that we will then provide a payment and incentive for providers to do. For example, referring to a doula, that's something, as we were saying, referring to a maybe non-traditional provider in a sense is maybe a new part of a workflow for a lot of traditional providers. So finding ways to make that more seamless and something where, you know, you automatically think, oh, I have a pregnant member I'm working with. Let's try to connect them to a midwife or a doula or a lactation consultant. So that's some of the things that we provide. We have a really wonderful care coordination team. So does Stephanie's team and Sunflower as well, who really work 24/7 to make sure our OB members' needs are met. Internally, one of the big things that I wanted to share with you all today is I know we were talking a lot about lactation support, doula support, and that access to care piece is really big. Something that Healthy Blue offers is Pomelo Care. This is available to all members who are pregnant or postpartum with Healthy Blue, and it's a virtual OB telemedicine program. They're considered a provider group that's supplement in addition to your primary care team for any Healthy Blue member. We've actually had a lot of really positive feedback from our members about this, mostly because the Pomelo team is available after hours, after 5 p.m. before 8 p.m. And about 75% of our members who are using this are using the service at that time, which is really lovely. And it's also such a big relief for people who live in more rural areas where it's harder to get to the doctor. So we have over 1,000 members right now enrolled with Pomelo Care in some type of way, either getting, you know, a virtual question answered about a symptom that they're having, primary care. Pomelo Care has a multi-specialty team, so there's also virtual psychiatric services as well. So you can have a psychiatric appointment, a therapy appointment virtually, and it's all covered via their Healthy Blue plan. Surprisingly, and well, not surprisingly, as Shelley was talking about 54% of our members who use Pomelo Care are using it for lactation support. So lactation support is provided via that. There's also virtual doula services via that program as well. And then Pomelo Network is, if you all are familiar with the doula network, Pomelo has acquired that, and they are a provider group that we've started working with as well. And I'll talk a little bit more about kind of what being a doula within KanCare looks like right after this. But and then lastly, in addition to that, I just wanted to highlight some CDOs that Healthy Blue and all the other MCOs work with as well. Nurture KC is a organization that provides wraparound social determinants of health, maternal child health support, even childcare for members in Northeast Kansas. Similar to that, KU Cribs is a program in the Sedgwick County area. And then there's KDHE New Mom program, which is also a support where they can provide different postpartum lactation services, different resources, car seats, things like that, and how to connect to different resources within where a parent lives. Another program we work closely with is Full Parent Foundation. They're a newer organization based out of the Kansas City area, but they provide in-person and virtual postpartum support groups. I had a child like 2 years ago, and I used Full Parent Foundation. And even though I live in the Kansas City area, I really struggled to get out of the house. So having that virtual option was really nice. And so they provide that for free as well as if you go in person, you get free childcare and dinner and lunch. So really wonderful. And then lastly, as Shelley shouted out to Kim's Birth Justice Society, Sapphire and her team have been really wonderful to work with. We have supported Sapphire's team in sponsoring a cohort of doula training in some of the rural and western counties in the state. And that's something we hope to continue doing and supporting. Just to increase the amount of doulas in some of the more rural and frontier areas of the state. So all in all, a lot of really wonderful things that we provide in addition to the value-added benefits that were shared earlier. So just want to share those. Stephanie, if you want to share some of yours.
Thanks. I don't have a formal presentation, but we work so in addition to the other MCOs, our Healthy First Steps team is a team of care coordinators and case managers, and they support the members, as we talked about, throughout 1 year postpartum, which is huge. We have registered nurses. Primarily, all of our nurses have a background in OB or maternal care, so that they can provide that support. And then we also have additional bachelor's degree trained support staff that are community health workers and outreach specialists that focus on the social determinant of health piece really specifically. Our team's located across the state. And I think that's made a big difference. We were a smaller team before KanCare 3.0 and some of the changes that were talked about. But because of the increase, having staff throughout the state, I can only be so many places. Lucia, our director, can only be so many places. But our staff being everywhere has really made a difference because they're really working to collaborate with those local agencies. So finding ways that we can collaborate, help support those local agencies, and then also get our members in touch and using those resources that are available to them. KanCare offers transportation assistance to get to appointments, things like that. But like Tamara stated, you know, that distance and time away from work, things like that is challenging. So we also offer a virtual care option. We have a doc chat that's available 24 hours a day that we launched this year and has been utilized a lot. The doctors are able to meet them in real time. Not only is it used for our pregnant members, but postpartum, I tell everyone, I was like, my kids, I feel like get sick about 5 minutes after the doctor's office closes. And as a new mom, it was always so scary. We don't want to have to go into the emergency room because we don't want to come home with 3 more illnesses than we walked in with if we don't have to. So really having that support, having someone who can write a prescription or say, yep, this one is something you need to go in for, has been a really, really great use. We also, have the value-added benefits that were mentioned. We offer virtual lactation support. We previously supported doula training before the launch to try to help increase that and are coming up with ways to do that. We partner with all of the community baby showers in the area and offer free pack and plays to anyone who attends those that are our members. But we know, again, with that transportation challenge in our Western group, we also, for our members, offer a virtual community baby shower every quarter where our members can Zoom in and get a safe sleep presentation and smoking cessation and all of those things. And then we can go ahead and get them that safe sleep pack and play just mailed directly to their home. So we're really trying to find things that members need. You asked what we're hearing from members. I would say some of the challenges we're hearing right now are just food. We offer a lot more foods insecurity options. Our high-risk members, we're offering some increased food for them, healthy foods. Offering blood pressure cups postpartum. The way the policy was written says pregnant members, and so it's been challenging for them to get them. So we're sending them directly to them postpartum if they struggled with PIH, because we know those first 2 weeks are so important. And then housing insecurity is still something that we're just hearing regularly as a challenge that we're working on. But that one is that's just something we're hearing from a lot of people. Utilities, bills, groceries, kind of the same thing we're hearing on the news every day. So try to think of ways we can help support moms.
Thanks to both of you. And please, for the participants, share your questions in the chat and we can get to them or compile them and answer them after the convening as well. Kind of transitioning to think about what you're hearing from members about how they're experiencing the services that are provided, and thinking about integrating the care team into being able to provide those services. What are you hearing from providers about how they're able to get connected with the MCOs and how they're able to provide services to parents in KanCare or pregnant beneficiaries?
Um, It depends on which thing we're talking about, but yeah, so providers are so busy, right? So they don't want additional things to do. So we're hearing that. We're wanting to make things as streamlined as possible for them. We are hearing challenges and we're working to address those. One of those would be the blood pressure cuffs that we're talking about. So getting those blood pressures in their hands has been a challenge. So we're working with the Kansas Quality Collaborative and other resources to figure out where those issues are. The WIC formula issue, and us taking over, we're working hand in hand and trying to do everything we can to make those more accessible and make it the least steps possible for the providers. So we're hearing their frustrations and we are working actively to help reduce those pain points.
I was just going to echo what Stephanie said. Just adding things to provider workflow already when they're feeling overwhelmed already is a lot. But something I have heard positive from a lot of our providers is that our MCOs are there to provide some of that SDOH support and those basic needs. So if you think about psychology and Maslow's hierarchy of needs, food, water, shelter is kind of key to any sort of health. And so the fact that providers can reach out to us, our care coordinators, Healthy Blue has an SDOH team, a housing team, an employment team. We have folks available at your fingertips to make sure you have those types of resources. So a lot of providers, we've been working really closely on trying to get provider groups more aware of what we offer so that they can hand that to us if they need to. And we've seen a lot more kind of positive outreach and positive response to that. And I think that's been really helpful, especially for the housing piece. That's just not something that a lot of providers have time for, but recognize that it's so important.
And I think the support staff too. I think when we first started talking about what we were doing, we heard some worries of, are you going to say something that's opposite of what we're saying? Kind of like that doula piece we talked about. Who is this extra person on the care team? But they found that we're there to support them. If they're struggling, their member, their patient couldn't get home because transportation didn't show up. Instead of them being on the phone with them, they have our staff's numbers and we can help support them in those challenges. If there's a problem or a need, or my member doesn't have food, we'll call us. We're going to work on it, like she talked about. So I think they're seeing that we're really an integral part of the team that's there to support and help.
Thank you so much. And we had a question in the chat that leads me to my next question is expanding on that. How are you working to integrate all care team providers, such as doulas, lactation consultants, CNMs, and CHWs, into the broader system of care? And how is that working? How has that been working?
Yeah, so for Healthy Blue, we have about 15 community health workers across the state that are employed with Healthy Blue. So they are part of the care team. They go through the same care coordination training. Our care coordinators, our community health workers, they all know each other. Our SDOH team, they all work together and are providing similar resources and communicate and collaborate with each other to make sure all members' needs are met. So for example, we had, even recently, we had a member who had, their care coordinator was out of office. And so the CHW who lived closest to them worked collaboratively and made sure that everything was communicated and we're able to visit them. So things like that are just really helpful in terms of CHWs. For doulas, we have doulas for all the MCOs that are directly contracted with the MCOs. So there's kind of two avenues that you can be a doula via KanCare, that is directly contracting with the MCO and or being part of a doula provider group such as the Pomelo Doula Network, for example. So either are an option. The really wonderful thing that Sapphire and Chile and her team did was to make sure that they reduced barriers to becoming a doula with KanCare. So removing the need for liability insurance was a huge piece for a lot of our doulas. That's an extra cost on them. That was hard to navigate. So the KMAP system and KanCare has made it really seamless to enroll. As a doula and Healthy Blue, we did some webinars earlier this year with our doulas or prospective doulas to share, how to bill. Now that you are a provider, what does that look like? And so we're readily available to answer questions. It's still obviously a new process for a lot of doulas, and it's new to be billing a managed care organization. I mean, even the thought of that for me, if I was a doula, sounds really stressful. So we're just trying our best to make sure to have patience and also be patient with kind of the new process. And we're learning a lot from our doulas as well as we do that.
Yeah. In addition, we also, with the postpartum coverage, I just want to point out, getting a year's coverage postpartum, sometimes this is the one time some of the members are going to have insurance for a while. So we really focus on not just that partnership with the OBs, but that partnership with getting them into a PCP, making sure they have a dental exam and an eye exam, and really partnering with all of them as well, working with our FQHCs as well, and being a good partner to them. So we do presentations to providers and review all the covered benefits, make sure they're aware of our internal supports, and then have a dedicated person. We actually have a dedicated specialist to outreach doulas and kind of walk them step by step through that challenging process that she was talking about, because it is overwhelming. So we have somebody who can, kind of walk beside them through all of that. And it's one dedicated person, so you're not stuck, kind of being frustrated. So that's one of the things that we did.
And it's definitely something I think that's like an adjustment for our provider teams as well. Having all these new provider types, they may not have been used to in their previous roles. So that's something that we've been learning and growing with KanCare to be better about. I think especially even our language around it, like calling doulas providers. I think that's step one. And just acknowledging that and making sure that our providers know, hey, they are providers, all providers, no matter what your credential is or what your role is. And that's key. And I think that's something that all three of the MCOs are doing a really good job about and kind of get the word out.
Well, thank you. That time flew by. And please, I would encourage everyone to continue asking questions in the chat. I'm sure you'd be open to answering those and to also connecting after the convening. I want to make sure we have enough time to get to our next panel, which is going to be a great discussion. So I will now turn it over to Shelby and the voices from the care team, which we're joined by 5 individuals today that will share lots of great information and insights into being members of the care team and how they shape policy.
Thank you so much, Sheena. As a quick reminder, if you have any questions for our panelists today, please feel free to drop those in the chat or our QA feature. It is now my pleasure and honor to introduce our next panel, which brings together unique perspectives from maternal care team members and policy experts across the state of Kansas. Before we begin our discussion, I'd like to share a brief introduction of each panelist. Brenda Bandy is the Executive Director of the Kansas Breastfeeding Coalition and an international board-certified lactation consultant. She works with Kansas Medicaid and private insurance to expand coverage for lactation support. Next, Dr. Mariah Kranz is the Programs Director at the Community Health Council of Wyandotte County. She has 20 years of experience in maternal and child health, public health, and community health worker programs. Next, we have Sapphire Garcia. Sapphire is the founder and executive director of the Kansas Birth Justice Society, a Black and Brown-led organization advancing reproductive justice and maternal health equity. She is also a community-based birth worker and reproductive rights advocate. Dr. Charla Smith is an associate professor at the University of Kansas Medical Center. Her research and advocacy focuses on Black maternal and infant health with an emphasis on community-driven solutions and policy development. And finally, we have Tara Stroda. Tara is a certified nurse midwife at Stormont Vale Systems, Flint Hills campus. She has more than 20 years of experience and has co-founded Delivering Change, Healthy Families and Healthy Connections, a collective impact model for improving maternal and infant health outcomes across Kansas. Thank you all for taking time from your busy days to join us for our conversation. I am certainly very excited to hear from all of you. So to start out, we'll go ahead and start with Brenda, and then we can make our way through our lovely list of panelists. The first question I have for you is some of you serve directly as members of the care team, and others support these roles through policy development and advocacy. Can you tell us about your role or the role you represent or the role you support through your policy work and your involvement in developing or implementing the policies we've discussed in earlier portions of our program? And then we'll go ahead and end that. I know that's a long question. We'll end that with how the role that you provide support in or contribute to policy efforts supports Kansas families. So Brenda, we'll go ahead and start with you. Thank you so much.
Thank you. Thank you, Shelby. That's a great question. And thank you for including lactation consultants as part of the care team. Our organization, I think it goes without saying because it's in the name, supports breastfeeding, but we do so in a way that we support those that are providing the support directly to families. And so, for example, we help with public health and the WIC program and hospitals and others that are providing the care to make sure that they have the latest information and training. And we also, as you said, Shelby, are working on the policy part of this. And also, as Shelay had mentioned, we really are trying to work as far upstream as possible to make sure that breastfeeding is an easy decision for families and is supported in a variety of settings. So we work on all those different levels.
Awesome. Thank you so much. Mariah, would you like to provide an overview?
So we provide direct services to individuals through our community health workers, and we have a dedicated maternal community health worker team. And then we also do some advocacy work on for clients and family members within the health system itself with navigation. And then we also do a lot of advocacy work on the systems level. So whether that is working with institutions to modify their policies that they have internally or identify strongly held but wrong routines within their practice system, or working on actually talking with legislators and helping to understand some of the challenges. As a nonprofit, we're very limited in what we can do regarding policy, but we do have a lot of conversations that help explore where are you going with this policy? We want to understand why you are behind this policy and how it's going to impact families. And here's what we're seeing and how we can work together to minimize impacts on families. And one of the ways that we've really addressed that is through our data sharing network, which we've recently launched, which is to address the data challenges we have, which is a huge policy issue because you can't have direct service. You can't have accurate information to base your programs or the work or even create policy if you don't have accurate, current, and accessible data for everybody. So that's one area that we really work with policy currently is within that. And then, of course, KanCare expansion, which is a challenge across the board.
Thank you so much, Mariah. Sapphire, can we hear from you next?
Yeah, so Kansas Birth Justice Society is really hyper-focused right now and for the next 3 years on implementation around this new doula reimbursement policy with Medicaid. So part A of that looks like training up a workforce of representative doulas from the communities that are most impacted, Black and brown doulas, doulas in the rural areas, so that people don't just have a doula who they can go to that's covered by Medicaid, but they're able to go to a doula that has cultural concordance, that shares a lived experience with them, that understands them on that enhanced level. And so right now we are well underway with our effort to train 200 community-based doulas across the state of Kansas. Part B of this implementation effort, and gosh, this is a really heavy lift. Every time I say it out loud, it hits me again. We are working with systems, hospitals, clinics, physicians, and other providers so that doulas are recognized as a member of the care team, a non-clinical member of the care team. And that is going to take a little bit more work. But one of the things that we've created is the doula directory. So if you want to see it, we're starting to backfill this with names of doulas, ksdoulas.org. And that's a free directory. Providers can access information on there. Consumers can access information on there. We want people to be able to reach out and connect with doulas, because this benefit does not do anybody any good if they can't find a doula right in their own community. This is just part of our policy work. We do lots of public facing work also. And I want to highlight that we do voter education for the hundreds of people that we serve every month. And so our work broadly is focused on policy solutions and public facing work to help decrease these inequities.
Thank you so much for sharing, Sapphire. I appreciate it. Dr. Smith, can you provide us with an overview of your work?
Yes, so the Kansas Birth Equity Network is ultimately a convening organization that convenes stakeholders around shared missions and goals to improve health, maternal, paternal, and infant health. We do some policy work. We are under the University of Kansas Medical Center, so we are limited in that, but we partner with Sapphire's organization and Brenda's organization to do some advocacy work and contribute in a research manner to help that work move forward. We do research and community engagement. And while we do not provide services, we do have scholars programs that are fellowships for OBGYN and family medicine residents to help them provide equitable care to Black and Brown families, equitable maternal care, and get some exposure to community and policy work. We also are launching a social emergency medicine, which is will be a part of our Birth Equity Scholars program for emergency medicine residents. As you know, many moms seek emergency medicine care first, and we want to make sure that they're getting equitable care when they go into the emergency room to seek care. And so we wrote a birth equity curriculum for AWAN, which is a nursing organization, to make sure that organizations who hire nurses as well as nurses can provide equitable care to patients across the nation. Those are AWAN members. So we do a lot of work around education and training, research on early onset preeclampsia, as well as policy work.
Thank you so much, Dr. Smith. We appreciate it. Tara, can you provide us a little bit of an overview of your role as a certified nurse midwife and the work that you've been doing?
Sure. So Tara Strota, nurse midwife. All of the women that just spoke, I have worked with, gotten to know, collaborated with for the two hats that I wear. And I think today I should represent the certified nurse midwives. Certainly I can't as one person, but in practicing in Kansas as my choice in a rural setting specifically, the certified nurse midwife role has not only started, but expanded and now collectively working as a collaborative model. And so day to day, that means bedside care from a certified nurse midwife with the expectation that midwifery is part of the care model. And I think we forget that that has not been the case for many, many years. And yet now the expansion project through TMA and other opportunities to expand midwifery care throughout the state is huge in my mind. But also, as you hear from my colleagues that are speaking today on this panel, but also prior, including payer class, the fact that all of us have said what worked before didn't really work. And so we'd like to change the entire prenatal delivery and postpartum care model is the most important thing to me as a nurse midwife right now. What we did about 12 plus years ago in my county is we recognized that, again, what we were doing was not working and it got really bad here. And so we basically looked at each other and said, the model of care doesn't work, and tried to reinvent the wheel. Again, all of these women and many of the others and men across the state, I called and said, please help. I don't know what we're doing, but it's not working. And what we began to do is what's called an integrated model of care now. Before we just called it the multi-tiered approach. And what that means is no matter where the patient accesses care, there's no wrong door. If she calls, if she uses electronic medical records, if she shows up in triage, if she comes to an OB or postpartum visit, she should receive all the screenings, all the referrals, and all the care, including equitable care at the time of service. And that also means that I, as a provider, need to know what's available, or the bat phone, we call it, right? So if it's a lactation concern, if she needs doula support, if it's home visiting, if it's, all of the things that you hear us talking about today, I shouldn't send her away because I don't know the answer. Because we don't. Providers don't know. Shocking, I realize, but we don't know all the answers. And so how and who we call next, or warm handoff, became a part of our practice now many years ago. And it's an expectation and should be across the state. So again, if I feel like the patient needs 5 different services, SSDOH screens were positive for 3 of them, she's got hypertensive disorder, and I need to get a blood pressure cuff, I should know where to go next or who to call. So certified nurse midwives are part of the collaborative care team. Sometimes we're the boat driver, I call it, and there's lots of us in the seat. Sometimes I am in the back seat going, hey, I have an idea. But all of us should be saying, hey, I have an idea and I want to help. Thanks for having me.
Absolutely. Thank you all so much for providing that overview and what such wonderful work is happening across our state. So I really want to thank you for all of your efforts. So we'll go ahead and give a pause for questions coming in to the chat in our Q&A feature. We do have one question, Brenda. If you could answer this one, that would be wonderful. So what are the gaps in Medicaid coverage for lactation support in Kansas?
I think that we have a lot of clarity about the number of visits and what is covered. I think where we need additional clarity is who can provide those services. And so I know we've been working really closely with the Medicaid office to clarify that. But I think we have been working as a coalition to build a diverse lactation support provider workforce. And so we have a lot of people out here ready to provide the care. And I think there's, as you saw in the chat earlier, a lot of questions about, well, can I submit for reimbursement? Can I? And so we just need some answers to those questions. So we have a workforce. We're building a diverse perinatal workforce. I look at everybody on this call. We are building a workforce, and I think now that the answer is going to be, and how do they get paid?
Awesome. Thank you so much. For our other providers, Sapphire and Dr. Smith, if you could answer the same question, but thinking from that perspective of doulas, what are some of those gaps in Medicaid coverage that you're seeing within the doula population? Sapphire, you can go first. Thank you.
I am so sorry. My
No,
sound
you're
was
good.
cutting out. I didn't hear but maybe 2 seconds of your question there.
Oh no, I'm so sorry.
If you'd like to go first, Charlotte, I'll loop back around after you.
I think that question is solely for you, but I'm happy to weigh in on the insurance part for patients.
I can restate it, Sapphire, if that would be helpful. So just following on that question that I asked Brenda, thinking from the doula's perspective, what are some of those gaps within Medicaid coverage that you're seeing for the doula population?
So the main one that we're seeing is doulas are really providing intensive services to their clients. Oftentimes, they're spending so many more hours with those clients than what is even allowable to be billed for reimbursement with Medicaid. And so that really needs to be expanded. We're happy that we have a good starting point on this, but doulas deserve to be paid fairly, and they deserve to be reimbursed for all of the hours that they're spending with clients. And that is really time well spent, because it's an unreplicated role. What the support that doulas are offering does is not the same as what the health systems are able to offer. It's a trusted relationship with that client. And we need more support for people who are giving birth in Kansas. So we need to be able to expand the number of hours that can be reimbursed under that benefit.
Thank you so much. Dr. Smith, do you have anything to add?
For doulas, no, Sapphire is our doula expert. I'm going to allow her to take on that question, but I will say, as it relates to billing and prenatal care, there is also a need to extend the time for those visits, and for the physicians, the nurse midwives, the community midwives, as well as the doulas to have, and lactation consultants to have more time with the patients, especially those that are at risk for things like hypertensive disorders in pregnancy.
Thank you so much. So, Mariah, could you speak to the same question for CHWs and maybe also cover what are some of the opportunities for CHWs within this space in KanCare?
Yes, so it is the CHW billing is very challenging currently in its current format. While explicitly the state plan amendment does not bar CBOs from billing, they are not able to bill. Neither are hospitals. Some FQs are able to bill in rural health centers. There are some that are successfully billing, I will say that. But for the most part, people that are trying to bill are not successful at it. And then a lot of the groups who do employ community health workers are prevented from billing. So as a sustainable model or pathway for community health workers, whether or not they are maternal focused or any other specialty focused, it is not sustainable. The increased reimbursement rate was a good thing that we did. We made an improvement there, but we still bar the majority of entities from billing. So there is a lot of room for improvement there, that could, just really build broader access to services and address some of these gaps that we're seeing. The way that community health workers were set up to bill is different than doulas. I really wish we were set up the same way as doulas, but it was set up differently, and it's much more limiting. I will say though, having that ability to bill in certain settings for community health workers is a start. That is a benefit. It does solidify the need that this is a need that should be there and should be present, and that it is justifying that we need to be able to do these services. In addition to that, there are lots of opportunities for community health worker sustainability across the state outside of Medicaid billing. There is Medicare billing opportunities, and with the new physician fee schedule that's coming out, that could bring broader availability to us, and especially with integrative health services the community integrative health services that already came out in this current year. So there is a pathway for that through partnership for CBOs, through contracts with entities. And then on top of that, there is a desire for the community health worker providers or service providers to identify how to build those contractual agreements with other partners to bill, not bill a payer, but bill the entity they're providing services for their clients. And some of that is laid out in the billing toolkit that Lucia shared in the chat earlier, that the Greater Kansas City Community Health Worker Coalition has put together. It's a wonderful toolkit. It is encompassing of community health worker type services. It is not specific to community health worker codes for Kansas. It is just bill for, and so it provides some benefit to that. And we also are working to identify how do we improve the billing structure for community health workers. What can that look like? How do we work with KanCare? It's a long process, but it's something that we are working towards, and so there is room for improvement there.
Thank you so much for that. I appreciate it. So we'll go ahead and end with the same question for everyone today. We'll start with Tara. From your perspective as a care team member and your subject matter expertise, what opportunities do you see to better support KanCare members in accessing care during pregnancy, childbirth, and postpartum? And maybe what's one thing that you're really looking forward to in terms of your work, or one thing that you're really hopeful about within the context of KanCare and the maternal care team? So, Tara, we'll start with you.
So there's always hope. And I I remember when breast pumps weren't covered. I remember when midwives weren't billable. I remember when we were at 75%. Thank you, Chalet. So there's always hope. And I think the struggle is what subject matter experts think should happen next is about 10% of what patients think should happen next. And as you asked those kind of that two-part question, my head immediately went to TikTok. Why did it go to TikTok? It went to TikTok because every day that I see patients, educate patients, help them with their birth or postpartum, I am enjoying their brilliance. 20 years ago, patients were not as educated because they're doing a lot of education on their phone. And they're coming to us way more educated and finding us quicker. Now, with that comes the negative part of misinformation and challenge. And so I have patient population in our setting with a high military population. I have a high setting of low SES patients, and I find struggle with there's just this interesting dynamic happening when we talk about best practice models and integrated healthcare and breast pumps and blood pressure cuffs. And I'm starting over with many of our younger patients to help build trust. So best practice model and all of the integrated care. And in one visit, I can get you WIC, breastfeeding, transportation, maternal fetal medicine, blood pressure cuff. And she's screaming at me, I need to trust you, right? So you're screening and you're ahead of her, but she's saying, hold on, I come to you with many things behind me. And so I would say the great hope is that we continue to do important work for our patients, but we have to stop and listen. And I'm finding that social media is making it really important that we hear what she's asking versus what we're telling her.
Thank you so much for sharing. Mariah, can you go ahead and share your final thoughts?
I think there's lots of opportunity for improvement across the board with working with KanCare and the MCO plans, especially for community-based organizations and non-traditional clinical licensed providers like doulas, like non-medically licensed lactation consultants, which Brenda and I are both part of that group where we don't hold a clinical license, but we hold an IBCLC, and even certified lactation consultant or counselors as well. You know, there are opportunities for supports like that, and we need to get a little more inventive and creative and recognize that there are supportive services that can be provided outside of a clinical licensure spectrum. And that doesn't mean we have to incorporate them into a clinical group. It just means that we need to know that they're there, they need to be supported, and we need to allow them to be fairly reimbursed and paid for their services. And that's something that I know Sapphire has worked very hard on and has made great strides, and so has Brenda. And I'm so excited to see that. And there's so much more we can do and so much further we can go. So I'm very hopeful there. And I really look forward to seeing how we continue to improve the integration of multitudes of services that provide help for these families and for all families across Kansas, because we often think of a certain subgroup of people that need these services, and it's not. We really have to think about midwifery care, about doula care, lactation care, community health worker care, as every single person residing within the borders of our state are eligible for these services and need these services until they tell us they don't need them. It needs to be an opt-out, not an opt-in model. And until we see that as this is a standard of care, not an optional care piece, we're not going to see improvement. And through the advocacy that Charlotte does and the advocacy that all four of us are doing on this call and others on the call too, I think we can get there. But we really have to work to tear down some of those silos we purposely put ourselves in to maintain our professional boundaries, but it's just harming families. And so the more we work to address that, I think the stronger we're going to get and the better outcomes for families that we'll have.
Thank you so much, Mariah. We appreciate that. Brenda, we'll turn it over to you next.
Thank you. I just want to echo what Mariah and Tara have said. And I think that the solution that our state found for doulas in allowing them to bill directly, while it's not perfect, is the same solution that should be afforded to lactation consultants and CHWs. The solution for one is the solution for all. And I will leave it at that. So my colleagues Charlotte and Sapphire have time.
Thank you so much. Sapphire, we'll turn it over to you.
Yeah, I'm really encouraged that doulas are now reimbursable with Medicaid, but the next step that we need to take is make CPMs, certified professional midwives, who are community-based midwives working outside of hospital systems, reimbursable through Medicaid. Until we do that, everybody in this state is going to lack access to appropriate culturally centered care, most particularly Black and brown birthing people. As somebody who is very near completing my CPM, it's really discouraging that the people who could benefit the most from my care, the folks who have Medicaid, who are enrolled, are not able to come to me and have that care covered. This is something that other states have done, and they've seen huge benefits from it. Community-based midwifery outside of hospital systems has a really long legacy in this country. And prior to 100 years ago, before the Shepherd-Towner Act was passed, all of the babies in this country essentially were delivered by community-based midwives. And so if we want to overcome these inequities that we're seeing, we need to go back to what worked before, which is community-based midwifery that's reimbursable.
Thank you so much, Sapphire. We appreciate it. Charlotte, do you have anything to add to this conversation or any last hopeful thoughts to share?
It's hard going after Sapphire. Let me just say that. Applause to you, Sapphire, for the work that you do. But I do think that it's also important that we begin to advocate for the inclusion of doulas as a part of the perinatal care team members, as well as others, that behavior specialists, others that are needed, making that a team and making that accessible, not just if you're receiving care within a healthcare system, but if you're receiving care within the community, you still have access. So making, although centering is not a model that's often used outside of the community, but making that virtual telehealth appointment available to all pregnant women in our community, and being inclusive of the family. So making it family care. So if there is a partner, if there is a spouse, if there is a person that is with that person, then you make sure that this is care for the family, and therefore they understand exactly what you're doing with the pregnant woman, so that they can also be advocates for them and making and acknowledging them within the healthcare system. I think the other thing is we need to train people. So it would be great if we would cover some equity training, or if you want to call it social medicine, whatever, but making sure that each person receives equitable care, and that warm handoffs are not just referrals to care, but warm handoffs are introduction to care. So that means working as a collaborative team and bringing those others into that care. I think the last thing I want to say is I think we should co-create equity-focused metrics aligned with our maternal core set, and what Tara talked about in integrating these care models. We should have some type of equity dashboard that measures whether or not those care models work. Lastly, I want to say we should turn trust, rather than using the term trust, we should start using representation, because the reason why we have less trust is because we don't have representation in our healthcare systems. And so whether you're Black, brown, or Native, you should have a physician or that you can see for your care in the state of Kansas. And so I think we have to stop saying, I know that there is a lack of trust, but we have to make sure that trust and representation are married. They're in a relationship together. And so once we have representation, we will have more trust.
Thank you so much. What an incredible panel. I really appreciate all of your thoughts and for joining us today. I'll now turn it over to my colleague, Rebecca, to review final wrap-up thoughts and procedures. So turning it over to you, Rebecca. Thank you.
Thank you, Shelby. And I know we're just about a little over time, so if you hang on with me for a minute or so, we're going to share a few more resources with you to make sure that you have everything you need as you continue on with your day and your week. So first, thank you, Sheena and Shelby, for moderating today's discussions, and a big thank you to all of our wonderful guest speakers for imparting your expertise and your insights. You are so valuable in this space, so thank you for joining us. And thank you to all of you who have joined the session today and shared your questions and thoughts in chat. We have dropped a link in the chat to the survey. Your feedback is extremely important as we continue to design these sessions and look ahead to the next year to see, what is of most interest to you all, what questions would you most like answered. So please take a moment to open up that feedback survey and share with us your thoughts. We really look forward to hearing about them. And then we are dropping one more time in the chat the resource guide that accompanies this session. It contains a lot of resources from KCHI as well as from all of the wonderful guest speakers you heard from today. They shared many great resources, articles, and websites that will be of really wonderful support to your work. So please make sure to download that PDF, and you will also see the link to the brief that was mentioned earlier. And lastly, we hope to see you for our final session in December, where we'll be exploring KanCare and reaching individuals who are unhoused. So please share the registration link for this event. We hope to see you there. And if you have attended all 4 sessions, you will receive a special token of gratitude for your commitment. And with that, thank you again for joining us.